Hello everybody, welcome to RAAONLINE. I'm Dr. Abinaya. I'm your pediatric faculty for the Nelson-based pediatric teaching course, which is called the Pediatric Pulse. So in the chapter discussion on genetics, so now we are in a very interesting topic, mucopolysaccharidosis. I'm sure you would have all seen children with MPS. There are various types of mucopolysaccharidosis, but so far your UG and PG period definitely would have come across at least one or two children with MPS. So here I'm going to highlight the most common MPS that we would come across, and this is something that is asked in your theory exams and even in practical. Sometimes if there are children with MPS during your examination, they could even ask you to present it as a long case also. Okay. So all these mucopolysaccharidosis, they all come into the lysosomal storage disorders. So they come under the broad term lysosomal storage disorders. So what happens in these lysosomal storage disorder is there is one enzyme which is deficient, and because of this enzyme deficiency, basically this is a lysosomal enzyme. So because of this enzyme deficiency, there is one particular product that is going to get accumulated in the lysosomes. What is this product? This is nothing but the glycosaminoglycans. And this glycosaminoglycan can get accumulated in various tissues. So they can get accumulated in the brain, they can accumulated in the viscera, they can get accumulated in the connective tissues. So it is a multisystemic involvement and it is going to be a chronic progressive disease. And based on the level of enzyme, the severity also will vary. So I just mentioned the word as glycosaminoglycans. So what is this glycosaminoglycan? This is nothing but this is a very large molecule. This is basically a long unbranched polysaccharide. Here you can see there are more proteins which are linked to each other with sulfate moieties. The major glycosaminoglycans which are involved in mucopolysaccharidosis will be around 4 to 5. Okay, you would have heard about chondroitin sulfate, dermatan sulfate, keratin sulfate, hyaluronan, etc. Is it? So these are the 4 or 5 molecules. They are the major glycosaminoglycans which are involved in these mucopolysaccharidosis. Normally, they will be degraded by the lysosomal enzymes, but because of the enzyme deficiency, abnormally they get accumulated and cause cellular dysfunction. So MPS is something that we have seen, but it is not very frequent. It is quite a rare disease. I mean, the overall frequency is 3.5 per 1 lakh population, and among all the mucopolysaccharidosis variety, one which is the most common is MPS type 3. So MPS type 3 is the Sanfilippo Syndrome. So MPS type 3 is the most common of all the MPS, followed by MPS I, which is Hurler, and MPS II, which is Hunter. The course of each mucopolysaccharidosis will be different, and we are going to delineate by studying about each MPS type in detail. So these are all the bone marrow and the visceral biopsy specimens. So basically they are presented here to identify the ballooning degeneration of these cells. So these are the ballooning degenerations that you can identify in these cells. Okay, and the tissues which are affected in mucopolysaccharidosis are varied. They can affect the CNS, they can affect the cardiac, they can affect the musculoskeletal, that is bone and cartilage, they can affect the connective tissue, etc. So it's a chronic, progressive, multisystemic involvement. So how do we classify the MPS disorders? So the most commonly studied are these 8, and in the order it is 1, 2, 3, 4, it is in the order. There is no MPS type 5 right now, there is no MPS type 8 right now. So it is 6, 7 and 9. So, and there are few more which were mentioned in the Nelson textbook, but I have not dealt in detail. So, I have put only these 7 to 8 over here, and I have not discussed about the last one, MPS 9 also here, hyaluronidase deficiency, which is a extremely rare moiety, and I have not discussed, right? So, from 1, 2, 3, 4, 6 and 7 are the ones which have been discussed in this video lecture. So, starting from MPS type 1. So, before we go on to the discussion, so we will read the very easier things in this tabular column. Okay. So, as you can see here in the inheritance column, all the MPS that we are going to learn now, or the most common ones, are all inherited in which fashion? autosomal recessive. So all are autosomal recessive except which? Type MPS type 2, which is the Hurler syndrome. So this is X-linked recessive. So this you should not forget. Next, about what are the GAGs which are getting accumulated in these mucopolysaccharidosis. So that is also important. So this could be quite confusing, but just remember 1, 2 and 6, 7 have dermatan sulfate. 1, 2, 3 and 7 have heparan sulfate. Type 4, the Morquio syndrome has keratin sulfate. So just remember 1, 2, 6, 7, dermatan sulfate accumulation. Heparan sulfate is same 1, 2, instead of 6 it is 3 and 7. Type 4 has keratin sulfate. So just for easier understanding and remembrance. Okay. So this is about the inheritance, this is about the GAG excretion. The enzyme deficiency can be quite tricky to remember, but maybe by frequent practice you will identify. So MPS type 1 is alpha L iduronate deficiency. MPS type 2 is iduronate 2 sulfatase deficiency. Type 3, there are 4 subtypes in type 3. The Sanfilippo has 4 subtypes and each subtype there is a separate enzyme deficiency which I will tell. Type 4 again it has 2 types 4A and 4B. 4A is gal N sulfatase deficiency, 4B is beta galactosidase deficiency. Type 6 is aryl sulfatase, type 7 is beta glucuronidase and type 9 is hyaluronidase. So please remember at least some of the enzymes for your remembrance. And of course why this is important is because most of these enzymes now with the advent of enzyme replacement therapy, we can effectively treat the children. The only downfall here is the cost and the lifelong management of these children with enzyme replacement, right? So there is a general rule which was mentioned in Nelson textbook also. So wherever there is a heparan sulfate degradation impairment, the mental retardation will be more. So I told you 1, 2, 3 and 7. So 1 is Hurler, Hunter, 3 is Sanfilippo, 7 is Sly, and these 4 have profound mental retardation or profound, we can mention here. So this is just a general rule. And impaired degradation of dermatan sulfate, chondroitin sulfate is mostly related to the mesenchymal abnormality like short stature, the bone abnormalities like dysostosis multiplex, etc. So we will read about the comparative features, but this is just a general rule of thumb. Mentioned that almost all of them are autosomally recessive inherited, and except for the Hurler syndrome which is X-linked recessive inheritance. And always whenever we get a child with MPS, ask for the family history, ask for the degree of consanguinity in the parents. And when we have an MPS child, apart from the index child, even the carrier testing for other siblings are definitely needed, and we have to offer prenatal testing for the parents also, which we should not forget. So before we move on to the each and every type of MPS, generally I told you already it is a multisystemic involvement. So look at the general structure of the child. How is the child's height? That is very, very important. So measure and plot it in the charts. So most of them do have short stature. The skeletal abnormalities will be there. They can have kyphosis, scoliosis, their gait abnormality will be there. They have short arms, they can have rhizomelia, and look for the typical facial dysmorphisms. Those facial abnormalities sometimes in the first 1 year or 2 years, the typical coarse facies may not be very, very evident, but during the course of the illness, they have this typical coarse facies, very broad nose, depressed nasal bridge, thick bushy eyebrows, etc. So all those, when you look at those children, you will definitely be able to identify. Look for the eyes if there is presence of corneal clouding or not. And look for their development, gross motor development, fine motor development, their neuro development, etc. And look for the cardiac and respiratory complications. And if we don't treat, if there is not adequate of enzyme replacement, of course, that is going to end up in mortality. So all these I am going to discuss. So these are the various organ systems involved, but all these we will discuss in the pertaining phenotype or pertaining type of MPS. So again we can classify, or we can just for remembrance sake there are three broad classifications of MPS based on the predominant affection, right? Predominantly neurodegenerative means it is Sanfilippo. So profound MR, profound hyperactive children, aggressive MR children of MPS will be type 3, Sanfilippos. And profound skeletal is very short, typical dysostosis multiplex, those rib abnormalities, kyphosis, their anterior beaking of the vertebrae. If you have seen one case of MPS, you will not forget. So typical skeletal changes. So only skeletal changes, the child will be very bright student, no corneal clouding, they will not have visceral manifestations, and their intellect is preserved. Such children, mostly it is MPS type 4, okay. And the others are mostly neuro and visceral. They will have this hepatosplenomegaly, organomegaly will be present. So this is also not very delineated, but in a broader way, if you want to remember, please remember which will fit into the neurodegenerative, which will fit into the typical skeletal, which types will fit into the neuro and visceral types, okay. So now we will start our discussion from MPS type 1, which is Hurler syndrome. We already saw how it is inherited, autosomal recessive inheritance. And next, what is the enzyme deficiency? It is iduronidase, alpha L iduronidase deficiency, and most of these disorders will have its onset in the infancy only. So between 6 to 12 months, you will be able to find certain abnormalities. So clinically, always see for the core facial features which are present in the child. Look for the cornea, if corneal clouding is present or not. Hurler will definitely have corneal clouding. Then look for the stature of the child. If there is presence of short stature, any dysostosis multiplex. What is this dysostosis multiplex? Is the collection of skeletal abnormalities that are present in these MPS children. It is called as dysostosis multiplex. Look at their development. They will have developmental delay. So I told you this is say type 1 and type 2 neurovisceral. So they will have some amount of developmental delay, and there can be neuro regression also. So with respect to the RS, ENT abnormalities like frequent URIs, recurrent otitis media, hearing loss can be present. CNS abnormality, there can be hydrocephalus. CVS abnormality, the cardiac valves can get thickened, and GI abnormality, most of them will have umbilical hernia. Never ever forget to examine the genitalia. They can have inguinal hernias also. So in one, we have three types. That is, so these are the three subtypes. This one, yes or she type, is the one which doesn't have intellectual disability, but the other two, one Hurler and one intermediate, that is one Hurler shy, will have intellectual disability. Okay, so this is with regards to the subtypes. So how are we going to diagnose these children is most often by the clinical suspicion. Once you have clinical suspicion, always ask for this test, urine for glycosaminoglycans. This is present in most of the labs, and without any delay, we can get the reports also. So if urinary glycosaminoglycans are elevated, we have to identify which type it falls. Then we have to go ahead and do the enzyme assays. Enzyme assays followed by genetic testing. Treatment is always enzyme replacement therapy. For MPS type 1, we have enzyme replacement therapy. The enzyme is called as laronidase. And for MPS type 1, we also have hematopoietic stem cell transplant. So when we do hematopoietic stem cell transplant early, that will improve the quality of life of the child, improve the neurodevelopmental outcomes of this child. So for MPS type 1, we have both enzyme replacement therapy and hematopoietic stem cell transplant. Remember, okay? So these are the short limbs, some amount of edema is there, umbilical hernia is present. These ribs are very broad ribs. So oar-shaped ribs, it's called as oar-shaped ribs. I will show few pictures of the skeletal changes in detail in the next part of this lecture. Right. So now we will move on to MPS type 2. MPS type 2, you know the mode of inheritance is X-linked recessive. Always when you start your answer, start with what is the mode of inheritance, what is the enzyme which is deficient. Mode of inheritance is X-linked recessive. What is the enzyme which is deficient? It is iduronate 2 sulfatase deficiency. Okay, it is present on XQ28. Onset of Hunter is little bit later when compared to Hurler. Hurler had its onset in the infancy. Here it is a little bit later. It is somewhere between 2 to 4 years of age. So similar to Hunter, most of the features will be present, but a Hunter always has his eyes very, very clear, right? So a Hunter is always clear eyes, no corneal clouding. So all the clinical features that you wrote for Hunter, short stages, skeletal changes, coarse facies, all these you can write, but there is no corneal clouding. There is developmental delay, aggressive behavior can be present in these children. CNS abnormalities like hydrocephalus is present. ENT abnormalities, RS abnormalities like airway obstruction is also seen. This is about Hunter. Diagnosis, of course, urinary glycosaminoglycan will be elevated. You do the enzyme assay will be decreased. For a treatment of Hunter syndrome, we do have enzyme replacement therapy that is called as idursulfase, but a hematopoietic stem cell transplant has not come for or not widely successful for Hunter syndrome. Okay, in contrary to Hurler. Prognosis is, of course, all these, in case if we don't treat, they will all result in this neurovisceral manifestations and the life expectancy will be short. So the earlier you start with ERT, the prognosis is good. Next, moving on to the most common type of MPS, which is MPS type 3, that is called as Sanfilippo Syndrome. These children, typically you remember, they have severe CNS involvement. A neurodegenerative MPS is Sanfilippo. Okay, they have a severe neurodegeneration, very, very hyperactive children, aggressive children. Progressive neurodegeneration will happen in these children. Here, neurodegeneration is the pathognomonic feature. They don't have much of corneal clouding. Okay, so no corneal clouding. Not much of even the somatic features like skeletal features will also be not evident. So no short stature, not much of dysostosis multiplex seen in these children. Of course, no visceral also. So it is only by this neurodegenerative changes, and we have to even pick up these children because it can be quite tricky. Without the typical coarse facial features and without the visceral involvement, it can be quite difficult for us and challenging for us to tell this child could be a possibility of MPS type 3. Okay, so for any neuro regression, we always ask for urinary glycosaminoglycan so that we don't miss this MPS type 3. Okay, now you understand, sometimes in our children, when we do the clinical evaluation for neurodegenerative disorders, we always think of MPS because of this feature only. They do not have such typical clinical features, especially 2 to 4 years, they might not have. Later, they can have those typical coarse facies, but this is something which has very, very subtle clinical features. MPS type 4 and all, it is very evident. Hurler, Hunter, coarse facial features, it is just written on their face, it is MPS. Okay. So, Sanfilippo, actually, I told you that it is also autosomal recessive inheritance, and here 4 subtypes are present for Sanfilippo. On all these 4 subtypes, there is a different enzyme which is involved. Okay, so making our job even more difficult. Okay, so A, B, C and D are the multiple subtypes of Sanfilippo. A is deficiency of heparin sulfatase. B is deficiency of N-acetyl glucosaminidase. C is acetyl glucosaminidase. D is N-acetyl glucosamine sulfatase. Of course, it is difficult for me also even to pronounce this, but more than the enzyme deficiency, I want you to identify, because when you have a child in front of you, you should say when you should think of this as a differential. I would believe in that way. So, please at least remember that there are certain subtypes. These 4 subtypes are present, and heparin sulfatase, of course, you have to remember, because I told you MPS type 3, clearly neurodegenerative one, and when there is deficiency of heparin sulfatase, heparin sulfate, that is the glycosaminoglycan, is going to get accumulated in the lysosomes, and when there is high HS, high degree of MR. Okay, at least remember that. Heparin sulfatase, at least you can remember if you don't remember the other 3 enzymes. And diagnosis is, of course, by enzyme assays, do a gene sequencing. Here, the treatment is for Sanfilippo, even though it is the most common, predominantly it is only supportive treatment and we don't have ERT. Gene therapy is, of course, ongoing for this. So, gene therapy for splicing, I'm going to talk about gene therapy in one another lecture of mine. So, gene therapy should save these children, okay. And it has got a very poor prognosis because it's a neurodegenerative syndrome. Next, let's move on to MPS type 4. I had a patient probably 5-6 years ago. This child came to me with only short stature. So, type 4 is something that doesn't have much of facial features. She had very, very subtle dysmorphisms, and she had a typical short stature, and initially we thought she had skeletal dysplasias, and later on when we started doing her complete skeletal survey, she had typical features of MPS, those anterior beaking of the vertebrae, oar-shaped ribs. We did her skull x-ray. There was a J-shaped cella. She had some amount of hydrocephalus also on neuroimaging. And yeah, so based on these skeletal changes, and only then we just thought of probably it is a type of MPS, and we did her enzyme assay, and it came as beta galactosidase deficiency. So she had MPS Morquio Syndrome type B, and currently this child, she is the only child of the family, and they wanted to get ERT done for her, and it was not available here. So the family themselves shifted totally to Australia for her therapy. So I remember the child very well. And yeah, so this children, a very bright child, a girl child. So you have gotten the answers for all of this, I guess. So the inheritance is autosomal recessive. The enzyme deficiency, I told you, my case was type B. So it was beta galactosidase. Type A is gallium sulfatase deficiency. So here again type A, type B are present. And typically this child is like good, and I mean there is no other abnormalities till 2 years. And beyond 2 years she started developing. I mean the parents noticed that the child is too short. Their only concern was short stature. Okay. So they usually come to us with short stature. And any disproportionate short stature, you have to evaluate for skeletal dysplasia and definitely for MPS. So skeletal dysplasia, short stature, pectus carinatum. She had hypermobility also. Very intelligent child. She was, I mean, even in the wards, she used to sit and study. So such intelligent child, very subtle coarse features in that child. We could see subtle dysmorphism. So not much of coarse facial features also. And this type 4 do not have leukocyte inclusion. So this is typically a skeletal problem. There is no visceromegaly, no hepatosplenomegaly. So even when you do, you will not be able to get any leukocyte inclusions. So we did her urinary glycosaminoglycans, which was elevated, confirmed with the enzyme assay, and we started her on enzyme replacement therapy. And I mean, we counseled her for ERT, and she was started on ERT. Now the child is getting ERT and she is doing well. So this prognosis always depends on stabilization of the skeleton. That is very, very important. So orthopedician and orthotic prosthetic appliances might be needed for this child. In a span of 1 year, they will not be able to walk. So this is purely a skeletal involvement type of MPS. So the treatment is basically the enzyme replacement therapy and of course skeletal stabilization for these children. So moving on to MPS type 6 is called as Maroteaux-Lamy Syndrome, and here the enzyme which is deficient is aryl sulfatase B. This is also inherited in an autosomal recessive fashion. So type 6 has both these skeletal features and visceromegaly. But here there is not much of an intellectual disability which is present. Here the intelligence is preserved. Type 4 also intelligence is preserved. Type 6 also intelligence is preserved. But the difference between 4 and 6 is that absolutely no visceromegaly in type 4, whereas type 6 has visceromegaly, right? Apart from that, the typical features, dysostosis, multiplex, everything you can write. Corneal clouding is also not present in type 4. Type 6 corneal clouding is present. So this type 6 is like something like a Hurler because of corneal clouding, and only difference is the intelligence is normal in these children. So you're diagnosing it based on the urinary glycosaminoglycans and based on the enzyme assay. And treatment is enzyme replacement therapy is present for type 6 also. Prognosis is it has got a good normal intelligence, but the only thing that we need is again orthopedic consultation for the skeletal thing, and sometimes they can have cardiovascular complications, so that we have to ensure. The rarest, I wouldn't say rarest, less common is Sly. Rarest is the last one, the 9th one. So this is quite rare. It is called as a Sly syndrome, which is MPS type 7. Here the enzyme which is deficient is beta glucuronidase. Okay, beta glucuronidase, autosomal recessive inheritance. Here clinical features can be very severe, like in the perinatal they can present as hydrops fetalis, and they can have all the features. They can have skeletal features, they can have corneal clouding, they can have facial features which are coarse, developmental delay. So this is kind of a very bad prognostic MPS. And diagnostic is the same. You are going to do enzyme assay and followed by genetic testing. Treatment is available for this in the form of enzyme replacement therapy, but the prognosis is quite poor for Sly syndrome. The rarest is the MPS type 9, which I have not discussed here. Very, very rare, and has got a very bad prognosis also. So, whenever you have clinical suspicion like a presence of coarse facies, organomegaly, skeletal abnormalities, a short stature child, developmental delay, always think of mucopolysaccharidosis as one of your differential. Do the basic urinary glycosaminoglycans quantification. If it is elevated, what glycosaminoglycan it is, identification, and then depending on it, do the enzyme assay followed by the genetic testing. Prenatal diagnosis is also possible for these children. So, what are you next going to carry on is imaging. So, imaging is very important. We have to do a complete skeletal survey for these children, and we have to do a complete workup. So, starting from MRI to look for hydrocephalus, to look for any other gray or white matter abnormalities. Then echocardiography, because cardiac valvular involvement can be present, audiological involvement, ophthalmological involvement. So, all these has to be done. Dental also, right? Coming to the skeletal survey, so not one X-ray, but we have to do a range of X-ray in skeletal survey. So, starting from the skull, so you have to do a skull AP and skull lateral. So, skull lateral, you will be able to find that presence of J-shaped cella or not. Come down, you do a chest X-ray AP view. Do a limb X-ray. So, one upper limb has to be done. Hip X-ray, that is pelvic X-ray we have to do. Lower limb X-ray we have to do. And a spine X-ray. So, complete spine is important. So, this is all these has to be done to call it as a skeletal survey. And this dysostosis multiplex is nothing but all the skeletal changes that are collectively referred to as dysostosis multiplex in these children. So, I will show certain pictures. Before that, in skull, what are the changes that can happen is, yes, macrocephaly you can find, dolichocephaly, these are the size and shape changes. Look at the cella, J-shaped cella can be present. Mandible can be very concave, there could be prognathism, and also the teeth, it could be widely spaced teeth can be present. Coming to the thorax, so look at the ribs can be oar-shaped, very broad ribs, clavicles very short, and their median end could be thick. So, coming to the spine, vertebral bodies could be wedge-shaped and lacking the normal shape of the vertebrae, and the anterior side there could be some amount of beaking can be present. Posterior side there could be scalloping. Okay, so anteriorly there will be beaking and posteriorly there will be scalloping. Odontoid hypoplasia will be there. Again, this is something that can predispose these children to atlantoaxial instability. There could be spinal canal stenosis also. So, what you can see here is, so ribs you can see there are oar-shaped ribs, and the vertebrae you can see that they are all typical wedge-shaped vertebrae, and where is the beak here? Yeah, so this is something anterior beaking of the vertebrae. Scalloping is not very typical in these images. So, you do a pelvis X-ray, you can see that the ilia is very, very hypoplastic, and look at the hip joint over here. The acetabular fossa is very shallow, predisposing to dislocation, and the femoral neck, one side only you are able to see. So, the femoral neck is actually in the valgus position. So, all these will predispose to dislocation and the typical gait of these children. Okay. So, you do a pelvic X-ray, and when taking X-rays of the arms and the long bones, you can find that there could be osteopenia, there could be diaphyseal widening, and maid-lung deformity of the radius can be present. And even the metacarpals and metatarsals, sometimes pointing also can be seen. So, typically this is a wrist X-ray, wrist and a hand X-ray. So, we'll start from the carpal bones. So, the carpal bones typically they will be arranged in a V-shaped configuration. Okay, there is a V-shaped configuration because the carpal bones are very, very small, and this phalanges are called as bullet shaped. Okay, so this is the normal phalange, this is the bullet shaped phalange. So, bullet shaped phalanges, typically metacarpals are all bullet shaped, and okay, some amount of trabeculations can also be appreciated here. Okay, so this is about the skeletal survey. MRI, as I told you, there can be hydrocephalus, there can be cerebral atrophies. in these children, do a MRI of brain and screening of the spine also. Spinal canal stenosis, odontoid hypoplasia, all these can be appreciated. Differential diagnoses are other lysosomal storage disorders. MPS is also coming under lysosomal storage disorders. Similarly, gangliosidosis GM1 type, mucolipidosis, sialidosis, these are all typically confused with the MPS. So, these are all other differential diagnoses. I have discussed all these in another video lecture also. Okay, so how are you going to manage? One thing is, I told you the typical or the after the typical clinical features, you are going to suspect, do a urinary GAG and enzyme testing, genetic testing, etc. Now you have identified, okay, this is the subtype MPS which is seen in this child. How are we going to do it? One is a definitive management, another one is a supportive care. Definitive management, you know, enzyme replacement therapy and hematopoietic stem cell transplant. Enzyme replacement therapy, still it is very, very expensive kind of an treatment because it should be lifelong. Of course, it is available for 1, 2, 4A, 6 and 7. And these are all enzyme replacement therapies which are available in India also. Okay. And hematopoietic stem cell transplant, I mean, especially very successful for type 1. And 6 and 7 also it is coming up. Okay. So, Hurler syndrome, we can definitely refer for hematopoietic stem cell transplant. So, I told you one pitfall for enzyme replacement therapy is of course the cost. Other pitfalls are it will not cross the blood-brain barrier. So, even in the neurological degenerative type 3, Sanfilippo, it is not going to treat the CNS disease because this will not cross the blood-brain barrier and it doesn't have any effect on the cardiac valves. I told you cardiac valvular thickening can be there. Corneal clouding is there. It doesn't treat all those. And this is weekly infusion and it has got very, very high cost, and in case we do it every weekly also, there is a danger of inhibitory antibodies that could form because of the enzyme replacement therapy. So, what it improves, I will tell you. I have a separate lecture on ERT, enzyme replacement therapy, but for you to understand, one thing is which it will not treat, which it will treat. That much we should know, right? So, I told you for this 5 to 6 MPS, it does definitely have enzyme replacement therapy in India also. And ERT, which will not treat is CNS disease, corneal clouding and cardiac valves. Which it will treat is visceromegaly, it will treat. So, the organomegaly will decrease, respiratory issues will decrease, joint mobility, cardiac function, it can improve. So, these are the benefits of enzyme replacement therapy. So, once you start enzyme replacement, you have to see for the clinical response, urinary glycosaminoglycan levels that we should quantify and the functional status. So, this is enzyme replacement therapy, and hematopoietic stem cell very, very successful for Hurler. 6 and 7 is written theoretically. I am not sure how much in India. I saw few papers of mucopolysaccharidosis in India, but Hurler it is very successful. 6 and 7 I am yet to find out. Right. So, supportive care, of course, we know CNS manifestations are there, multisystemic involvement, isn't it? Respiratory manifestations are there. So, we have to do a proper supportive care. Pediatrician being the center, we have to involve all the specialists. So, involve ophthalmologists for the corneal clouding, any glaucoma, strabismus, etc. Involve the ENT surgeon for the deafness, and involve a respiratory physician because they have this obstructive sleep apnea. They can also have central apnea, recurrent ear infections they could have, sinusitis they could have. So, involve all these specialists. And for the dysostosis multiplex, orthopedician and orthotic person has to be there. So, if there is a recurrent dislocation, fixation need to be done for genu-valgum, osteotomy and fixation. For a spinal problem, spinal fusion, regular physiotherapy, all this will increase the quality of life in these children. And of course, a pediatrician with a pediatric neurologist. For any seizures, anti-seizure medications can be given. If there is hydrocephalus, a VP shunt. Sleep disturbances in these children treated with melatonin. If there is a cardiac complication, of course, we have to see the echo, check the BP, hypertension can be there, valvular involvement can be there. If there is a valvular thickening, replacement is going to be the only procedure. So, always think what all complications you anticipate in these children, write one by one by one. So, when you are in a tertiary care center, you have such a child, of course, what you are going to do is, you are going to refer, okay, go and see a cardiologist, go and see an ophthalmologist. That's how we do, right? So, they have to see everybody, and each of these subspecialists or each of these other specialists, they will also keep their these children under follow-up and they will call them repeatedly. So, a very motivated family is important. Otherwise, they will abandon the child. We have seen cases where the child is being abandoned if such a diagnosis is being proven. Very sad state. Yes. So I have two case scenarios, I guess. So this is a case scenario of MPS only. 1-year-old boy, recurrent URIs, hepatosplenomegaly, developmental delay, coarse facies. So what is present? Everything is present. Coarse facies is present. Developmental delay is present. Recurrent URIs, hepatosplenomegaly. So it's a neurovisceral. And there is corneal clouding. Neurovisceral, it is 1, 2, 6 and 7. Where there is corneal clouding is not present is Hunter, there is no corneal clouding. So it could be 1, 6 and 7. 6, Maroteaux-Lamy, 7 is very rare. So I think we can eliminate now. So 1 and 6, it is between 1 and 6, right? So then you do a urinary glycosaminoglycans and it is elevated. So you are thinking of some MPS in this child. And 6, mostly corneal clouding is not present. Okay, it is plus or minus. So by all this, we will think that, okay, probably it is a type 1 Hurler syndrome, and we do the enzyme deficiency and see, we check for the enzyme levels. It is deficient of alpha L iduronidase activity. So probably this is a, so after the enzyme deficiency report has come, mostly we will confirm it is MPS type 1, but before this point, probably it is a type of MPS type 1. So just by, I'm just guessing, see, I also don't remember what these case scenarios are. And I had few case scenarios left and then I just finally uploaded. So what I want you to think is, once you have a MPS type, just by the permutation and combination of these symptoms, just think what it could be before the enzyme deficiency report comes. So for type 1, I told you, enzyme replacement therapy is available. Of course, it is very, very expensive and then you have to do it weekly or 2 weekly. And hematopoietic stem cell transplant is going to treat these children excellently. So it's a life-modifying treatment for them. So please counsel the parents for hematopoietic stem cell transplant. Unless you go for a stem cell transplant, give a good multidisciplinary supportive care. Right. Coming to the case scenario type 2, I will not tell the answer. You will think and let me know. Okay. A 5-year-old girl with hyperactivity, speech delay, behavioral issues. So till this, we cannot even think it is MPS, right? Some minor somatic features similar to MPS is present. You do an MRI brain and it is cerebral atrophy. As a part of screening, you have done a urinary glycosaminoglycan and it has come as elevated. So this is a purely neurodegenerative type kind of a presentation and you will tell me what answer it is. Okay. Yes. So recent advances in MPS. I told you after the enzyme replacement therapy, after the hematopoietic stem cell transplant, the latest one is gene therapy. So you modify the genes and we will see how the genes are getting modified. There are splicing, there is interesting Cas9, CRISPR gene sequencing and all is present. I'm going to explain it in another lecture. So gene therapy is very promising in these children. Second thing is substrate reduction therapy. Even the glycosaminoglycan you can reduce. But this is also in a preclinical use only. And personalized medicine approach and good supportive care is necessary. Newborn screening. Of course, we don't involve MPS in newborn screening. Predominantly, even as private practitioners, what we face is the cost and compliance with these children. The newborns, they don't come back for newborn screening. And most of the parents, they say at the right moment when we utter the word newborn screening, they say, don't know doctor, nothing is needed. So what I do is I do newborn screening of the top 6 diseases or the top 7 alone. I don't do the entire one. In that, mucopolysaccharidosis is not covered. So we have to, involve this in newborn screening. I think we should start doing it. Right. So this was one paper I saw, Indian experience with mucopolysaccharidosis. Contrary to the global report where MPS type 3 is the most common, in India, Hunter is the most common. And there is a huge diagnosis delay because these children, they come with short stature, they come with subtle clinical features in the first 2 years. This dysmorphism will not be evident for general practitioners. So there is a big diagnostic delay, huge, 3 years after the symptom onset is present. Okay. And there are certain case reports. Even we had presented one, this child MPS type 4 as a case report. So we have to wait and watch how much gene therapy can revolutionize these children's lives. So this is something which we have to be proud of. The first successful enzyme replacement therapy was done at AIIMS Mangalagiri. And now, yes, few other centers are also giving, I think 5 to 6 centers all over our country, private countries, which is not the government ones. Trust hospitals are all providing enzyme replacement therapy, but early clinical suspicion is very, very critical. So key takeaway is, you are now aware of what are the facial features, what are the clinical features, right? You are now aware that this MPS is a chronic multisystemic disorder. It is a lysosomal storage disorder. Early intervention, and if there is already a child, genetic counseling for the affected families, and counseling them for hematopoietic stem cell transplant if it is a clear case of Hurler, that is MPS type 1, is very, very essential. Okay. So any other doubts, any other clarifications in MPS is welcome, and if you want me to add any further detail, you can also reach out to us. Okay. Keep listening to our lectures, keep supporting us. Thank you, everybody.